Thank you very much for giving me the opportunity to talk and for the nice introduction. So yeah, we're Berlin-based at the university both and at the National Public Health Institute. So today I'm going to talk about QSP, so Quantitative Systems Pharmacology of PEP. So how did we get into this work? Basically, it was kind of the WHO and some guys from the International AIDS Society asking us some specific questions that could only be answered with, or not answered, but at least addressed with modeling at that point in time. And that was, the purpose here was to develop or reshape the new WHO guidelines on PEP. The publication came out 1.5 years later, so just now. If you're interested, yeah, you can just use the QR code for that. All right, so this is a joint work, mainly between my PhD student, Lang Xin, who did a lot of the mathematical modeling part. Simon Collins is a treatment advocate for HIV, and Julie Fox is an AIS member and an epidemiologist. So here the link was to, both do the QSP modeling and also to have input in terms of the relevance for both the people actually taking PEP and for the guideline development. All right, this also builds on past research done together with Craig Hendricks and Jessica Harborough, among others, and also recently with Rob. and also on some past work with Saye and Laura, actually, who developed some POP-PK models. Okay, so what is PEP about? PEP denotes the application of drugs after a viral exposure in order to reduce the infection probability with HIV. And currently what's recommended is that kind of an NRTA backbone is taken. That's usually tenofovir plus either emtricitabine or lamivudine. And then a third drug is added, which is either a protease inhibitor or an integrase inhibitor, depending on what's available in which setting. And the national and international guidelines here have differed quite a bit with regards to how to use it and which drugs to use and how many drugs to use. And so this is what we actually wanted to address and what also the WHO was interested in revising the guideline. So why do we need modelers for this? And there are two answers to this. So first of all, this is really something where you can fill a gap because PEP is kind of the most kind of data-poor field of research, at least in terms of human efficacy data. Because as you can imagine, I mean, you cannot do kind of a randomized controlled clinical trial with PEP because you simply cannot deny people drugs to prevent infection. So therefore, it's also hard to assess the efficacy, which I will just tell you in a second how this is quantified for prophylaxis. Secondly, and this makes it ideal for a QSP approach, it's kind of multifactorial. So there are lots of factors that weigh in. And of course, it's the pharmacology that you're all well acquainted with. It's the PK/PD, the drugs used, the particular PEP dosing schedule, but also things that relate really to the viral exposure, the within-host viral dynamics, just after the exposure, and also a lot of behavioral factors that relate to adherence. So how long do people adhere to a given PEP regimen? Okay, so this is where we wanted to come in. And the second thing is, why does PEP actually work? There are two main things that one needs to think of here. So the initial events after viral exposure, they are quite stochastic. So as you know, not every exposure leads to an infection, even in the absence of any drugs. A particular PEP regime would reduce that probability. So it's stochastics, it's probabilities, right? So we're talking about infection probabilities of less than 1 to 10% per exposure, depending on the type of exposure. PEP will reduce that. Secondly, during these very initial events, the infection has not become irreversible yet. So what we think makes infection irreversible is the establishment of so-called latent viral reservoirs. What is a candidate for this is T cells that go into latency after viral genomes have been integrated. And from what we know of the half-lives of these cells is the following. So once you have one of these latently infected cells, it would take about 20 years to clear it with 99% probability. So meaning with PEP, you need to act before this has happened. So this is your window of opportunity. So the specific questions that the World Health Organization here and the IAS were interested in, where we can ship in, is kind of when do you initiate PEP, how long should you take it, and how do these first two questions depend on the drugs that are used for PEP. And there are other questions that I will not talk about here, which is kind of this prevention continuum from PrEP to PEP. But we can also address this in the question answer session. So coming to what they're interested in is basically the PEP efficacy. The PEP efficacy is, any prophylactic efficacy is quantified usually as the reduction in incidence. Oops, can we do this? Oh yeah, we can. All right, so this here would be kind of an incidence of infection for a given intervention. And the denominator, you have the incidence of infection without that intervention. And from this, you calculate, from any clinical trial, this is how you calculate prophylactic efficacy. So the same thing you can do when you do a bottom-up modeling. You just replace these rates of infection with the probability of infection, and that correlates almost one-to-one because infection events are rare. And so this is what we are going to calculate in our approach. So now for a QSP approach, what you typically do is you just combine all available data sources, and you do this in a way that you can actually address now questions that couldn't be answered before. How we do it here concretely for PEP efficacy is we use POP-PK models developed previously with collaboration partners for both tenofovir and emtricitabine and dolutegravir. This allows us to now model any kind of dosing schedule and also adherence schedule. And from this, we will know the concentrations actually at the effect site, which we here assume are the PBMCs. Secondly, for some of the drugs here, it's a bit more complicated to actually really model their direct effects. And therefore, we built this mechanism of action models previously for the NRTIs, particularly for tenofovir and emtricitabine. We integrate both of these together, and then what you have is kind of a time-dependent inhibition of certain rates and viral replication. So this is then how we integrate this. So we have a viral dynamics model, which basically just describes the initial events of infection. You have free virus, early infected cells, late infected cells that then produce new viruses. And within there, you can also create these latently infected cells. Then the drugs, they inhibit particular rates here. These are the ones with the little t in it. And what we do here from this model, we directly compute the probability that the virus get extinct. This is a little mathematical trick, which allows us to do this very, very efficiently. We can integrate, lastly, when we have this, the kind of exposure by really considering like how many viruses get transmitted and so on and so forth. This is this equation kind of below these ordinary differential equations, and from there the probability of infection can be computed as the complement of the extinction probability, and that is then the HIV risk reduction or the PEP efficacy. So all of this kind of gets just plugged together and then can be played out. So while all the individual building blocks of this framework here have actually been validated as good as we could with kind of external data, the end result of this is, of course, difficult to evaluate if you don't have PEP efficacy data. So therefore, we do this little trick by looking actually at PrEP efficacy, which we can do because there are actually relatively good clinical trials out there. So what we did is we first modeled this for cisgender women, looked at just the clinical top-down data, what's the efficacy that we would expect, and how many individuals would be infected if we simulate these trials, and we compare this to the observation. That fits quite well. So this is just bottom-up modeling, different data sets, and just gives us a little bit more security on what we do does make a bit of sense. And the second is for the MSM, and this is just some recent work which we now submitted, and also there it does make sense. So in other words, we have a model that can model PrEP efficacy. For PEP, it's just a little bit of a mathematical trick. It's the same model. Now, if we go back to now these questions that we want to answer here, the first was when to initiate PEP. And this when to initiate basically translates directly into this question like, when is the infection irreversible? And that translates into the question, has this latent reservoir already established? If we let the model run without any drugs, what we see is that this latent reservoir would normally establish within or after approximately 50 hours post-exposure. So here we start to lose our momentum, and so any PEP has to act before that. And there's also some sensitivity with parameter estimates and so on, but this is the first thing. So PEP has to be initiated early so that the infection is not irreversible yet. The second part is, and this is super complicated to read, I apologize for this, there are two interacting factors. So if we now initiate drugs after some lag time, then the second point is we have to eliminate all replicating viruses. So there are two ways that PEP can fail. So either it fails kind of before we start with the drugs, here, or it fails after kind of the PEP course has ended, because we didn't just achieve all the clearance of all viral compartments, as shown here on the right. Okay, so now let's take actual POPPK models and plug them in. And then what you can see is two things. So first, we wanted to elucidate like how quickly do we actually have to act when we have concrete drugs. So here, tenofovir, emtricitabine, and also the triple drug combination of tenofovir, emtricitabine, and dolutegravir at the standard oral doses. So what you see here is like if you would just do a two-drug PEP, you would immediately have to initiate it in order to prevent infection. However, if you add the third drug, you buy yourself some time. So you can actually have a short delay of roughly 48 hours between exposure and the initiation of the three-drug combination. You take that for 28 days, and then the infection rate would still be reduced by about 90%. That's our prediction here. The second thing that you can do is, of course, you can fix the time from exposure to starting PEP, and then investigate how long do I have to take PEP. So is it like 2 weeks or 4 weeks? And here you can see definitely that there's a big difference for this triple drug combination that includes dolutegravir if you take it 2 weeks instead of 4 weeks. So 4 weeks is definitely indicated. And of course, you can do all kind of parameter sweeps with this thing. This runs fast, and find your sweet spot in terms of this delay and duration. So the basic take-home message from this is this time to PEP is kind of the most critical factor for post-exposure prophylaxis. 3 drugs is better than 2, and they should be initiated within 48 hours if possible. And if this triple drug combination of tenofovir, emtricitabine, and dolutegravir is taken, then 4 weeks duration of PEP is better than 2 weeks. And this has to do with this: the longer you wait, the more virus you have, and the longer you need to clear it. Okay. So since this was WHO, not all drugs are available at all places. This is what we heard this morning. And the question is, since tenofovir and emtricitabine is quite often available in Africa in terms of pre-exposure prophylaxis, is it possible to self-start with the available drugs and then add the third drug, for example, dolutegravir, later on? And the simple answer here is yes, it is. And this is quite nice because what you can actually do if, let's say, the first 2 drugs were initiated 24 hours post-exposure, if you add the third drug like 7 days later, and the whole PEP course is 4 weeks from the first initiation of the 2 drugs, then you still achieve like a 90% reduction in HIV incidence. And I can also explain why this is. So what the 2 drugs do is they don't fully prevent the infection, but they lower basically this initial viral expansion. So you start off with less virus, and therefore you need less time to clear it. So you basically just win time with it by initiating with 2 drugs. And yeah, and so this also went into the guidelines. So basically it's advisable if not all the 3 drugs are available to self-start with the 2 drugs and then get the 3rd drug later on. So in terms of PEP, actually, our modeling here by and large confirmed these most recent guidelines from the US and the UK. There's some twists to it. The efficacy is related to 2 factors. So it prevents the establishment of these latent reservoirs, so the irreversibility of the infection, and it has to ensure that all replicating virus is eliminated. The time to initiation is the most critical factor here. 3 drugs is better than 2. If the 3 drugs are not available, then it's possible to add the 3rd drug a bit later. And 4 weeks is better than 14 days. There is a synergy also between prior PrEP and PEP, which I didn't talk about. And all of this kind of is now, or some of this went into the guidelines, and more details are also found in the paper. And I just don't want to end just with that. So we are actually coming from the PrEP field. So since there's such a good crowd here of pharmacologists, we are always looking for people to collaborate with, particularly with regards to POP-PK models. We are very much interested from the public health perspective in long-acting PrEP, and there are, of course, a number of questions that are interested, that we're interested in here for actually also developing the national guidelines. So these are kind of the people that are involved in here. So Langsin is basically the one that did most of the modeling. There is a lot of other people in my group that are concerned with PrEP modeling. And I would like to thank also the collaboration partners at this point in time, of course. And thank you for your attention. And since this is a PK conference, I also just wanted to put, some PK profiles on the slides. So thank you very much.